You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
This is the RxGenius podcast, where we discuss better healthcare with the professionals who are making healthcare better. Hosted by pharmacist and epidemiologist Paul Liabenow, the show dives into the science, strategy, and real-world stories shaping modern medicine.
RxGenius podcast. I am your host, Ryan Paul, and we have an incredible episode for you today. Jason Torress. Jason, thank you so much.
Thanks for having me.
So Jason Torress, managing partner of Sana Capital. He has an incredible organization, folks. I met Jason just a few weeks ago, and we had a really meaningful conversation for me. As you guys know, there's a lot going on in the world right now, and as it relates to healthcare, it's so important for us to focus on underserved communities, vulnerable and marginalized populations, and be able to focus on how we get funding in the hands of underserved founders that are doing that work. And Jason is doing just that. So I'm so excited to have him on to talk about that today. Jason, give us a little bit about your background.
Oh, sure. Jason Torress, Sana Capital, born and raised in New York City, one of Brooklyn's own, first gen. Got into healthcare and investing really via mom, who was a social worker in New York City in the 80s and dealt with vulnerable populations, a lot of substance use disorder, a lot of domestic violence cases. And so she really protected those that needed help. And that's how I got introduced into healthcare and then into this space. Engineering undergrad, went to RPI, and then made my way onto Wall Street via a program called SEO, Sponsors for Educational Opportunity, which gave me an opportunity to join a Wall Street firm. I started my career at Salomon Brothers way back when that existed, and they were looking for quantitative talent, and that's how I got my break or my start. I moved over to Deutsche Bank. I was trading, and there I covered kind of full circle healthcare companies and then technology companies, and that's really where I learned about investing, and we'll talk more about that.
Yeah.
So that's how I got into this space. I went back to business school. I went to Stanford. I came out, got the entrepreneurial bug, and I've been in this space ever since. I started out as an angel and investing my saved up bonus money, and had a couple companies go public in a pretty meaningful way. And that's how I got into this space. And all the ups and downs along the way. Companies go public. I've had companies go bust, and everything in between. And so I've since, spun out, launched Sana. Sana is the Latin root word meaning to heal. In Spanish, it's a synonym for a cure or a remedy. And that's what we do. We remedy and those gaps that exist in healthcare. And they're heavily in these areas that are underserved populations and overlooked founders.
Yeah, so important. Maybe I'll give the crowd a little bit about why this is so important to me. I grew up in privilege. There's no doubt about it. I wanted for nothing. I had the major league education. I was 100% the poster boy for white, straight privilege, right? And I say that boldly because my life fell apart in my 20s. I became addicted to drugs, became an alcoholic. I failed out of school. My parents wouldn't talk to me almost for 8 years, actually. I was lost. And it was in all of that I found out what my purpose was going to be, right? Because if it wasn't for those things, I would have never known what it looked like to be vulnerable. I never would have known what it looked like to be marginalized, and I would have never come in contact with a community that was hurting. Thank God, fast forward a decade later, right? In recovery, doing well, launching businesses, and currently in the process of launching a hedge fund. And by the way, I'm not a finance guy. I'm learning this as I go along from guys like Jason. But I say all of that to say, because number one, we do another podcast called Mind Bridge on mental health and addiction treatment that people really know, right? My background, because we talk about it a lot. So this isn't new information for a lot of our listeners. But I restate it for the fact that today I have a nuanced view of the world because of my experience, right? Because of the people that lifted me up when no one else would. And so I, in my quote unquote privilege, knew that it would be my obligation in the healthcare space to work with vulnerable and marginalized communities, whether it's women's health, whether it's the LGBTQ plus community, whether it's minority communities, whether it's under-resourced communities, whether it's unhoused communities. That would be my calling, because it was actually that community that saved my life, right? So important. So I wanted to get that out there, because that's why when I meet people like Jason, I have to make sure that the audience is edified and there's an exhortation that happens around the work that Jason's doing. So Jason, where I'd like to go next is, talk to us a little bit about who you're serving as a VC firm.
Yeah, so the populations that we serve are the least served, the least connected, the least covered in terms of insurance. Our mission is pretty simple: increase access, improve outcomes, and reduce costs. And the way that we go about that, and who that really means, is those are Black communities, Latino communities. So they're on very few different spectrums. Could be gender, so women's health, maternal health, age, so allowing seniors to age in place with dignity and not in a remote, cold, distant facility from the removed from their families. LGBTQ populations, right? Folks that need access to care that depending where you are, you may not have access to care. You may be excluded from care, and even just geography. So rural, urban, right? What you have access to and when. And so it's many different stratifications that we look for to find and identify the largest gaps that exist in healthcare. So if you think about a distribution curve, think about that area underneath the bottom, call it 25%. Whoever is the least served, the highest cost, the worst outcomes, that's the population that we're serving.
Yeah, it's so important. And I think that when we continue to have this conversation, we have to have a conversation about how we're actually funding it. And that's a lot of where you come in, right? It's not just, I guess the cool part is what I've learned is that you have this beautiful strategic eye for how to launch, how to execute, how to make these things happen, bring these to fruition in the communities that most need it. But let's just say for a second, I'm an underserved founder and I have an idea, right? There's something going on in my community that I've been impacted with, and I have identified an opportunity, whether it's in digital health, whether it's a healthcare service, some type of IT. And I come to you and I say, Jason, here's my idea. Would you back me in this endeavor? Talk to us about the best practices for approaching a VC firm like yourself and how we would go about doing that in a way that would be approachable, right? Where you would say, yes, yeah, we'll definitely have a conversation with you, because there's obviously an alternative to that, which is, no, we're not going to have a conversation with you. So what does the positive look like?
Yeah, the best conversations I have with founders are when they know and really understand their business and the economics of their business. So many times they lead with the heart, and that's okay, and that's fine, but it may not end in the VC world. It may not be VC backable. So let me give you an example. The first question I ask is who benefits and who pays, to make sure that this is repeatable, scalable, sustainable, and that it's outside of a grant. So this isn't a grant that's going to need to be topped up every year, 2, 3, in order to do this passion project that you feel very strongly about. So making sure that, okay, knowing who you serve. Do you serve payers? Great. If you're serving payers, then you likely have to save money for the payer. And so be a cost-saving solution. And especially in this administration, everything is focused on cost savings, fraud, waste, and abuse, cost transparency. Like that needs to be core to what you do. If you're provider facing, then you're likely going to be a revenue enhancement, revenue generation, or revenue protection, so they can remain relevant. Providers, hospital systems, and provider networks are under incredible pressure around just reducing the spend and cost constraints. So you could see how if a founder comes and says, yeah, we serve payers, we serve providers, it's like, all right, you probably don't really know your business because the two are at odds. Right. And we haven't even talked about patients, which is funny, is that we're talking about healthcare and we haven't even, this is the first time we're mentioning patients. And, right. And so, and increasingly they're becoming more and more part of the equation, whereas historically they've been pretty much irrelevant. But the more that we have the cost component shifted more to the consumer and earlier in the spend in the year, then the more they become purchasers in a meaningful way. So early, but trending sort of up. So if a founder says to me, we serve payers, we're a cost containment solution for them, we increase access to caregivers, which are the kids or the grandkids who are the caretakers. Typically, here's what they look like. And we provide them the tools that they need to make sure that their senior is aging in place with dignity and not have to go to a nursing home. And this is how we get paid. And this is how we reduce costs. And so they lay out down to the CPT code level. Mm-hmm. The ultimate thing that they want to do is the heartstrings, and they pull at that. But you don't get to do that until you've done the cost component first. And that starts with who you serve, payers or providers, and increasingly patients, but not so much. Mm-hmm. So really understanding their business. Now, there could be a scenario where, we serve payviders or ACOs. And then you really get into the kind of the efficiency of healthcare and the continuing of the bending of the cost curve. But that's a very small number of much smaller market, which is fine. I mean, still, healthcare is massive. Healthcare is $4.5 trillion of spend a year. It's almost half, somewhere between 45 and 50% of the entire global healthcare spend is in the U.S. And the majority of which, 80-ish% of that, is IT and services, which is payer and provider and increasingly patient facing. And whereas roughly is pharma, and then all the discovery devices, things like that. So knowing the business, knowing how you make money, and then secondarily having the impact that you want to have.
Mm-hmm. Yeah, that is really important, because I know that when I started off, I definitely had no clue. So I don't think I could have gotten. I think I had the passion. I think I had an understanding about what I wanted to do, but I didn't have a long-term vision, and I certainly didn't know the economics of it. And wow, was I lucky, right? When I launched Health Clarity, I had two small investments of $50,000 from two different guys, and within 3 years we had an 8-digit business, a large 8-digit business, and but at the beginning I had no clue. Going back. This is 13, almost 14 years now. I had no clue what the economics were. I thought I did. Now looking back, I had no idea. I wouldn't have been able to articulate to a venture capital firm the economics of my business. And so, I just count myself lucky that we're at the right place at the right time with the right people to be able to have that success. But I think it's important because I think that a lot of folks don't really understand the economics of the business idea that they have. And that's not abnormal, right? Especially when you're talking about businesses that come out of that passion project mentality, right? That I'm going to save the world in this category at this time, at this place, and I'm not going to let anything stop me. And then they think that slide deck that really expresses that passion is going to be enough. And they find out, at the end of the meeting that it just wasn't, right? It just wasn't. So with that said, what does a good presentation look like? I'm coming in, I need to know the economics. I need to know whether I'm serving payers, providers, and ultimately, the demographic geography of the patient, all of these types of things. How am I preparing myself to give that pitch to a VC firm?
Yeah, I mean, look, we'll provide a template. It's a pretty basic, short template. Make sure you have the vision. Make sure you have the team, the why now, what's different, and all of the things that you would expect. And it's 10, 12 pages or slides, and it's more to really talk through it as opposed to read. It's not a business plan. Most try to cram a business plan into a deck, and that's no one's going to read that. We've got to be able to flip through this on the phone and get an idea of like, oh, okay, all right, and to be interested enough. These are talking pieces, and really the wow factor has to be with the founder, with the leadership and the management team, and so that's just to make sure you get a meeting, and the goal isn't to get the check from that deck. Have a good, solid, make sure you're communicating what you want to communicate. It will iterate. You're going to iterate on that thing, 30, 40 times based on feedback. Oh, I didn't get this, or this didn't come across. Oh, I didn't know you had subject matter expertise in-house. I thought you had, right. And so you'll iterate until you're communicating what you want to communicate. And so there's no special slide that you have to have in, but the basics show that you're solving a big problem, and that you're unique in your approach and why it's going to work, and how you're going to win.
Yeah. So you were mentioning a little bit about payviders. I want to go a little tangent for a second. You're talking a little bit about payviders. ACOs particularly, which I've seen in the marketplace, have just really advanced a lot of the methods in which we go about receiving and giving care, and the way in which we go about rewarding networks and paying for actual services. What are you kind of seeing in that market? It's very easy for us to say, here's a solution for the provider, here's a solution for the payer, and this has got to trickle down into a really fantastic solution for delivering healthcare, right? Because that's the point. But what are you seeing as it relates to payviders, as you call them, ACOs, those types? What are you seeing in the marketplace that's really exciting to you?
I mean, that's the future of healthcare, is going to be in this ACO values-based care system. It's slow to get there. So what are we seeing? We're seeing this very slow migration from fee-for-service to shared revenue to shared savings or partial cap, and then finally to full cap. To be able to migrate, that's a skill, especially for if you're a provider-based group to be able to do that, or a payer-based group to be able to do that, because you've got to have dual administrations going on simultaneously, which is adding a whole other level of complexity. So it's pretty challenging. It would almost be easier to, I think, just binary from one to the other, full clip, not have
Right.
different populations and different. Oh, this is an elder population; they're part of the ACO, but this one isn't. And so it's like, how do you know who you're treating and when and how? Because it's not polite to say that you would treat patients differently, but the fact is they are, because of the incentive, because of the payment system and the models.
Right.
And it's, you don't get rewarded for, you would think that if a provider had phenomenal outcomes and were able to see patients, and that they would get rewarded with higher reimbursement or more patients, but they don't. They actually get penalized. And so it's this weird kind of thing that goes on. And same thing with payers. And so we're locked in conflict. And we want to untangle that. And you can untangle elements of it. It's on the margin. And so what we're seeing is those that can migrate and dual chew and walk and chew gum at the same time. They're going to be the ones that remain, because there is a migration to values-based. It's slow, and you've got to be able to weather this slow, and having all the tools in place to report on, oh, well, these are the revenues, well, these are the expenses, these are the cost savings, these are the, and interact with groups that you would know otherwise be competitive. They're, co-opetition in this particular case, but not over here. And so it's being able to navigate that. So that's the evolution that we're seeing.
Do you think that the system itself would make it difficult to have value-based care across all lines of coverage? So you're talking about, private commercial versus Medicaid versus Medicare versus TRICARE versus VA. How do you kind of view the multidimensional aspect of our healthcare system in general, and how we pick up opportunities in value-based care in each one of those?
Yeah, it's really on the contract and who pays. So who's paying and who has the contract to do that. What we saw in this evolution first was heavily on the Medicare side, so elderly patients, and we started to see some pilots with CMS around location or geographic based ACOs. It was called the AHEAD program.
Okay.
I really liked how that was going, because that lends itself really well to overlapping with the provider networks in that particular area. So I'm excited to see kind of where that shakes out. I'm hoping that there's enough cushion in these reimbursement models that they can calibrate, like, oh, okay, this worked well, this didn't work well. The difficult part that's always going to be is, as long as we have the government, commercial payers, the who benefits, who pays, and then when is a challenge. Because so things like wellness and prevention will always be outside the realm of what is really going to be focused on, unless you're a Medicare or a Medicaid beneficiary. Then it matters, because who benefits, who pays is the same group,
right?
And you'd want that. Whereas if you're in a commercial payer, the wellness and prevention really is not that exciting, because by the time I reduce diabetes or CHF or COPD, like these sorts of things, you're not going to be on my health plan. So I've paid for a benefit that someone else is going to receive, not me, not my company. And so, there's areas that I get excited about for self-insured employers and for commercial, like maternal health, because it's in a short enough time frame that you actually do see the benefit and you can reduce costs significantly. But there's others, around, wellness and prevention that I just don't like for that segment. I do for government sponsored programs, Medicare and Medicaid, because who benefits and who pays and when is tight enough for those groups that it makes sense, that it's worth the investment.
Yeah. Yeah, and I think that's why I asked the question is I was hoping that you would get there, because we kind of talked about it offline the last time we talked, was, this idea that who benefits and when they benefit and how they benefit are all aligned when you're talking about a government run program. But then you get into commercial insurance, and then the question is, well, how the heck are we going to be able to benefit from this when at the end of the day we're basically paying for something that's going to benefit our competition in many cases?
Yep. They're going to benefit what's, either the next employer or Medicare.
Yeah, so I think that, again, another important conversation that we need to have on a national level is who is benefiting, when is the benefit most advantageous, and how is it benefiting the population? And I think when you talk about wellness and prevention, that's a difficult conversation. I think that's a difficult conversation for multiple reasons, both for political reasons, but also from a healthcare perspective, because you got a lot of people fighting to garner that benefit, right? That's why when I saw probably early 2000s, when the wellness benefit, right, when the wellness benefits and self-funded health plans really started to kick off, and people 5-6 years in said, this isn't working. We're spending all of this money on wellness and prevention, and we're not reducing our actual overall spend. In fact, our reinsurance and our medical stop loss coverage is going up, and we can't figure out why. So, I mean, I think that you're right on for that. So the question then becomes, as we kind of refocus back to how do we get our arms around an underserved population, that vulnerable and marginalized community, what do we have to do as innovators, as idea makers in this process to be able to identify those really specific things that are going to be important moving forward?
Yeah, and that's exactly what we do at Sana. We study the policy, what comes out of Washington, D.C., what comes out of certain states. We translate that to a business strategy and then help execute on that. An area that I really like now that I didn't like a couple years ago is maternal health. Black maternal health, Latin maternal health has awful outcomes. So comparable to some poor third world countries in terms of outcomes.
Yeah.
And that's just sickening to have in one of the sort of wealthiest nations ever on the globe, that we have mediocre outcomes at best and these massive disparities. And we're spending multiples more per person than anybody else. So we spend the most, and what do we get for it? Like, if we had phenomenal outcomes, we were living to 120, all of everyone, and everyone else wasn't, then great. Then maybe but we're not. We have this similar life expectancy as Cuba does. So what's really going on? Where's all the spending going? And so and so that's what do we get for it? And so how do you have the impact on that? Well, you have to look at that, that distribution curve. Who is the least served? Who is the most costly? And let's get them to the mean. And so getting those to the mean, two things happen. One, your mean is now much more concentrated. And two, the mean has shifted, call it to the right. And that gets us closer to health equity, rather than having this very wide, flat distribution curve of outcomes, of access, of costs. And so that's what we look to do. So to give an example, a few years ago, I would not be excited about maternal health. It was wildly invested in, underspent in terms of reimbursement. The codes, you couldn't make a business out of it. In this prior administration to the one we're in now, they had a real focus on access, and beginning with populations that were underserved. So Black maternal health, for example, is a fantastic place to be investing in. Why? Because the government now has mandated and allowed reimbursement for the outcomes of maternal health of the high cost populations. Mm-hmm. So even in this administration, with this attack on DEI, so the demographics, we have to take the demographic part out of it, the skin color out of it, but focusing on the costs, great. Let's focus on the high cost populations that are blowing up the model, that are not making that are making it impossible to have reasonable, rates of increase, where we have to have high rates of increase because we've ignored these whole, demographics and populations, whatever the stratifications are, they're blowing it up because they're high cost, high utilizers. So back to, Black maternal health, if you focus on that, even just over deliver to that population, that demographic, you're going to more than make up for that multiples in an ER reduction. You reduce one or two of these costly hospital stays, complications that they'll have. That's a big win. That's a win for the system. That's a win for healthcare. That's a win for, forget the demographics. That's a win for just, for the patient. And so that was learned early on with what's now called managed long-term care, long-term system supports. Early on, there was this, let's try these nursing home diversion programs, and let's, try to keep people out of a very costly facility, keep them in the home and just deliver a bunch of stuff to them in the home, meals, OT, PT, and they have better outcomes. They're happier. It's a fraction of the cost. So it's a lesson, learned there, and taking a page out of that book. So the who benefits, who pays, and when is within a time frame that makes sense for these self-insured employers and that are ensuring that that demographic. So forget about it's the right thing to do. It's the right thing to do economically first, and it happens to be the right thing to do.
Right. And it's interesting that in most cases that's the case, right? Mm-hmm. And I think that we forget that, right? When policy decisions are made, we forget that what is reducing cost, or cost avoidance at a minimum, is actually improving the system in and of itself. And I hope that we can continue to have that conversation. I know that we are, at one of our businesses, we are deploying a harm reduction strategy at home, right? That is saving commercial plans thousands and thousands and thousands of dollars of avoidance costs every single month, simply because we can go in, give Sublocade to those OUD patients, keep them out of the ER, keep them out of residential treatment, keep them in day programming, intensive outpatient programs. And they're having great success as a result. We're talking about thousands, just that. We're talking Sublocade, IOP. They're not going back into residential treatment. They're not overdosing, and we're seeing huge cost savings. And we're obviously reaping the benefits of that, right? Because even in a Medicaid situation, Medicaid is reimbursing even better in many cases than Blues, United, Cigna, Aetna, Humana. So it can be done. It can be done. And so I think that we get caught up with, unfortunately, the politics of it, and it skews, it blurs the vision of the fact that this is about taking care of a human being, and that if you are in healthcare, right? Like if you're in healthcare, like that's what you do, right? Like beyond everything. Doesn't matter if you're on the right or the left or whatever it may be. There's a human being. You have committed to providing a service. If you provide that service, then you've done your job. And if we could just get back to that, I think that we'd be a lot better off. And obviously, I was frustrated today, Jason, right? And I think this is a good kind of way for us to kind of wrap this up, because I want to hear more about your view of equity and how we move forward, right? Under any circumstance, how do we move forward and make sure that health equity, which is important, right, for a myriad of reasons, is continued to be pushed on the forefront, right? I don't know always how to approach this, right? Because as my audience knows, I'm a bleeding heart, right? I am, and I am that guy that has to remember to talk about economics in the slide deck. because I will just, blather about what I believe is right. But when we talk about health equity within the context of healthcare, right, and how important it is across the geographic, across the demographic, to be able to better risk manage, right? I mean, commercial plans are doing this either way, right? They are managing this risk. You're doing it in finance every single day. You're managing for a risk. You're managing based on populations. You're managing based on demographics. You're managing based on geographic locations, right? Like, I know the population that has a propensity for type 2 diabetes in Michigan. It's Wayne County. And I know exactly what population it is. And I know exactly what to do as an epidemiologist to treat that population with pharmaceuticals. But unfortunately, those of us that are deploying population health management resources, that are deploying pharmaceutical services, that are investing in healthcare organizations, our voice kind of gets drowned out with the what and the why and the who and the how of the noise that kind of seems like an umbrella, even right now, to get in the way of the fact that at the end of the day, I don't care what you believe. I just don't want you to get in the way of me being able to take care of my patient. Like, at the end of the day, like, you can shout from the rooftops, but don't get in the way of me and my patient. So what do we do from a health equity perspective to make sure that beyond the rhetoric, beyond the noise, we can continue to be able to focus and do our jobs in a way that's meaningful, in a way that's effective, and most importantly, being able to still do the right thing in the midst of it all?
Yeah, it's a big question. I mean, you'd have to blow up the entire model and start from scratch to really get at the root cause. But aside from that, you get to the middle by starting on the edges, and you navigate your way in there. So pick the least served, highest cost population and serve them, because it's worth it. It's worth it multiples over to reduce a readmission rate, to avoid a costly hospital stay. Even if you provide more services than you otherwise would, it's just worth it. And so identify the super high cost utilizers and just over deliver to them to start to chip away and sort of lob off that wide part of the curve of access, outcomes, costs, and lob that off and kind of tack it onto the middle. And so chipping away little by little, figuring out the thing that you want to, that you're bleeding heart for, whether, it's maternal health, whether it's LGBTQ care, whether it's, seniors aging in place, whether it's, grandma who's out on a farm, who's in a rural area, to have access to. She doesn't have care when she needs it. She doesn't, so that's sort of, so pick the, pick how, and then figure out the right model, how you're going to save money for payers or increase revenues for providers. And so that really is a model. With this administration, what I tell founders is to take away the demographicness of it, typically the race and gender, and certainly LGBTQ. There's all these things that you can't say, otherwise you become a target and a lightning rod. And just to put it to a cost. These are the high cost populations, and then also, and always include veterans, because let this administration say no to the veterans. Right. And so being that for example, veterans have a disproportionately high in terms of mental health that needs to be figured out. That's wide open space in certainly in the US. And we need to have a real answer for that, because I don't think we get too far without starting to think about mental health as health.
You're absolutely right. I love that you said that, because that's we're having that conversation on a regular basis at Mango Health is that addiction treatment is mental health. Mental health is health, right? Yeah. It's not addiction treatment. So we're going to do Sublocade, or we're going to do Suboxone or Subutex, or we're going to do naltrexone or whatever, the Vivitrol. And then we're going to, now there's this bucket of mental health. So now it's lithium and Abilify and Depakote and whatever the case may be. No, the bottom line is that, for instance, 52% of all individuals that have an alcohol use disorder are diagnosed with bipolar 2 and are not medicated, right? And then we wonder why they chronically relapse. Well, it's because they're solving for a problem, right? And so if you now take that statistic and you place that in the middle of the veterans population, right? Then all of a sudden you can now say, okay, what is it going to take? Digital health services, medication-assisted therapy services, psychiatric medication management, sexual health, drug-related infectious disease, bringing all of these services to bear in a small population to solve a really big problem. And it's those types of multi-pronged approaches that not only, I think, bring really great ideas to the table, but they actually solve the problem that we're trying to solve, which is taking care of people, right? I mean, at the end of the day, I will beat that drum. We don't care how you get there, but we can get there if we care about the people that we're serving. And so, yeah, there's so many things out there. So what I want to make sure that we don't lose in all of this, because, I'm now excited because I think I have an idea, just talking with you, is that, what does the rest of 2025 look like for Sauna Capital, right? How are you deploying capital? What are you looking for? What's the resource?
Yeah, so we've raised some capital. We're raising more. We were anchored by Eli Lilly. So that's the largest, I think, healthcare company on the globe. They backed us, and a number of other institutions. And so we're going around to other folks that care about the same things: access, outcomes, costs. So other providers, other payers, and healthcare foundations. This isn't concessionary. We're here to make money first, second, and third, but where we do it makes, we invest in economically viable solutions, repeatable, scalable, sustainable, so that they're here. And so we're, deploying in areas, got a term sheet out in a maternal health company, really like that space. Even with the current bill that has largely been carved out of the cuts. So that's good. So that, remains. And so whatever ends up getting passed in the Senate remains, an attractive area. We've got to figure out mental health, and hey, look, you've stepped up early and kind of shared, if it wasn't for my close friends and family, I lost my significant other in 9/11. And so that was one of the darkest, points in my life, but not for the support that I received to help pull me out of that very dark time, wouldn't be here today and having a positive outlook. So very similar. I'm not stopping. And I found it sounds like you have too. I found my purpose, and my purpose is to invest in, the folks that need help the most, whoever they are. That's who we're serving, in terms of the population. Generally right now, it's along those stratifications, whether they're veterans, elder, poorer populations, maternal health, demographically, if there's, Black, Latin, whoever's the least served, that's who we're serving. And we're, in solutions that are economically viable. Like this isn't a grant. We're venture capitalists. And so we're here to, invest in these growth solutions.
It's powerful. And as I started off in the beginning of this, it's important that people know who Sauna Capital is. It's important for people to know who Jason Torress is, because they're doing good work. And I'm so thankful and grateful to be able to surround myself with people that get it, right? There was a time, right, when I felt like I was the only person standing in the room, right? That I was lost, that I was hopeless, that people didn't get what I was feeling, right? And I even feel like that sometimes today, that moment where you're like, why is everyone else not having the same heartache about this that I am? And what I realize is they are. They absolutely are, and they're willing to do stuff about it. So thank you for the work that you're doing. Thank you for sharing your time with us. And Jason, you're awesome, man. Appreciate it.
Thank you so much.
So for RxGenius, that is it. Thank you so much. Have a great day.